All right, so yes, I'm going to be talking to you all today about sort of some of the history behind therapeutic hypothermia, as well as what we have learned over the last 20 years. So our objectives today will be to really talk about the origins of cooling, some of the landmark trials, including some of the early animal and pilot studies, but also some of the major pivotal RCTs that were done back in the early 2000s. Then we'll review some of the many studies that have been done over the last 20 years to help us refine the approach as neonatologists and people who work on the NICU. We'll talk a little bit about present and future directions in this space, and then end with some conclusions. So I think, as all of us know, as neonatologists and NICU providers, one of the most tragic things that can happen to a family is neonatal HIE. And I think that's because it's unexpected, sometimes unexplained, and it's really mired with loads of uncertainty as far as outcomes go. So, of course, all families want to come into the hospital and have a happy, healthy mom and baby in a situation like this, but unfortunately their baby ends up with us in the NICU, critically ill, being told they may have a brain injury, and there's a lot of uncertainty with prognosis and future often. And not only is this a huge emotional burden and mental burden for families and providers, but worldwide, it's a really large sort of global burden for for medical resources. This was a study that was funded by the Gates Foundation that was published last year that looked at global burden of neurologic diseases over the past several decades and scored all comers, neurologic diseases, adult and pediatric alike, and scored the disease based on the sort of disability adjusted life years of life lost. And as you can see here, globally, neonatal encephalopathy is the second as far as burden and for these factors. So it's a huge problem, a major cause of neonatal mortality worldwide, especially in low and middle income countries. So it's a huge problem, and it really can cause a very tricky and difficult NICU stay for families. It's also a disease that's pretty complex and difficult to care for. So many of you are probably familiar with this schematic, but it's one of my favorites because it really does illustrate how incredibly complex this disease is, and sort of the course these babies can take, or this injury can take, over the first minutes, hours, days, and months. And so this is really an injury that is going on for months. And this is both a good and a bad thing. It can be a fortuitous thing because it gives us many different facets of which we can intervene and provide therapies. And so there's a lot of potential here for new therapies and new ways to protect these babies' brains after injury. And I think one of the special things about this area of research and this area of clinical care is it is a true bench to bedside success story. And so as someone who does bench research, I really love hearing about the story of cooling, because it is truly a great illustration of taking things found and observed in animal models and taking that to the bedside. So if you look at this timeline here, back in the 1950s and 70s, people were already describing this sort of patterns of brain injury in monkeys that had been asphyxiated, and looking at pathologic specimens and describing the injury there. Another huge landmark in this area of research in neonatal HIE was in the early 1980s, when the sort of gold standard rodent model for this injury was developed, called the Rice-Fanucci model. And this was advantageous because, as you can imagine, non-human primate work is very difficult to do for many reasons, and it's getting harder and harder. It's very costly, it's very regulated, and so just very difficult to do. So the rodent model being developed in the 1980s, that is still one of the major models used in this disease to this day, 40 years later, was a major landmark. And then there were some really wonderful landmark studies done in the 90s by Marianne Thorson's group in the UK using a piglet model, as well as Alistair Gunn's group in New Zealand using their sheep and lamb models, that really did more work describing both the injury, but also the effect of therapeutic hypothermia on the injury. And so all of this really amazing bench work culminated in a number of randomized clinical trials that were done in the early 2000s, which we'll talk a little bit more about here, that showed effectiveness for neuroprotection for this population. So how does hypothermia work? Well, many of you probably know a lot of this, but if you think back to that complex injury cascade that I showed you earlier, probably the reason that hypothermia works so well is because it acts on so many facets of that complex injury cascade. So hypothermia decreases the cerebral metabolic rate by 6 to 7% for every degree decrease in body temperature. And what this does is essentially prevent some of the increased metabolic demand that can come with injury and decreases that secondary energy failure. So it allows you to decrease your demand for ATP, oxygen, and glucose by the brain to give it time to rest and recover. It also decreases cerebral blood flow, which can help with any cerebral edema, intracranial pressure. It can help actually treat seizures in this way as well. It decreases free radical release, inflammation, and it allows time for endogenous repair of the brain. So it's multifaceted for a multifaceted disease, and that's why it works really well. So like I mentioned, in the early 2000s, a large group of babies were involved in several clinical trials, really well done, randomized clinical trials, the NICHD, the TOBY trial, the ICE trial, the ICER trial, and the Neonatal Network trial as well. So all of these RCTs involved over 1,500 babies and randomized babies with moderate to severe HIE to therapeutic hypothermia for 72 hours, as we provide today in our units, and cooled them down to a level of hypothermia that was considered mild, 33 to 34 degrees Celsius, and found that that was neuroprotective for those babies, with a really good number needed to treat between 6 and 9 in these trials. And so when you think of all the interventions that we provide in the NICU, this is actually a really strong evidence and a really strong number needed to treat for this patient population. In addition to that, there were very few adverse outcomes or sort of risk of harm. So number needed to harm was very low. And most of the side effects, as you all know and see every day in your care, were really involved sinus bradycardia and mild thrombocytopenia. So much more benefit than risk is what these major clinical trials found. And so with all of that work that was done beautifully in the early 2000s, finally, as units began to adopt this practice over the first sort of decade of the century, it finally became standard of care, the gold standard for babies with moderate to severe HIE being incorporated into ILCOR, AAP, AHA recommendations, as well as NRP. And so we have an effective therapy, and now what? I think one thing we have to remember is, yes, this is an effective therapy, but as we all see all the time, taking care of these patients and know from the trials, it doesn't provide neuroprotection to all patients. In fact, it doesn't provide neuroprotection to a significant number of these patients. And so there's a lot still to be learned here in this space. In addition to that, another question that came up early on with providing this therapy and more units getting comfortable with providing this therapy is the question of whether the outcomes have improved with experience and time from those original clinical trials done in the early 2000s. So to start to address some of that, there was a trial done by the NRN that was published in JAMA in 2017, looking at a more contemporary cohort of babies cooled, compared it, and when you compare it to the NICHD trial done back in the early 2000s, you can see that actually as a community, we have gotten better at this over time. And things that we've been able to optimize have led to even better outcomes than what was published in those original trials. And so even lower rates of death and disability, moderate and severe HIE, as well as mortality, and Bailey scores, cognitive scores. So that is reassuring that this pans out in larger groups, but also that the community NICUs have gotten better with optimizing things compared to those initial RCTs. But many questions remain about ways to optimize cooling and other therapies that we can provide. So one of the other initial questions that came up over the first few years of when this was being provided widely in NICUs was, what are the outcomes when these patients go to school? All the original RCTs, for the most part, focused on 18 to 22-month outcomes. And so were these children growing up to have more problems, or were they continuing to benefit from what they received as neonates? Another question that came up is, this is a great therapy, so could we make it even better by giving more of it, longer, deeper cooling? Is that effective? Another question that came up is, what if we have to start late? All of those RCTs only included kids that were identified and able to start therapy within the first 6 hours of age. And we all know, any of us that work at referral centers, that this comes up not infrequently, that babies are either identified late or unable to receive therapy before 6 hours. And so is that okay? What about mild HIE? This was a population that was not included in the original RCTs, mainly because at the time it was thought that these patients have quote unquote normal outcomes. And so the risk versus benefit was not worth it. And they were not included in those initial RCTs. Is this a therapy that could be provided for preterm infants? All of those RCTs were either 36 weeks and up. A few of them provided or included babies that were 35 weeks and up. So that's another hot topic question as well. And then another huge area of research that has come up in the meantime is, since there are so many babies that aren't protected or helped by therapeutic hypothermia, are there other adjuvant therapies that can provide neuroprotection for that patient population in addition to cooling? So to address that first question of whether these kids are, whether these good outcomes or these improved outcomes in babies who receive therapeutic hypothermia pan out when these kids go to school. And so this is a look at school age patient outcomes, kids mostly in the 6 to 7 year outcome study, looking at that population. And what this data shows is that it does pan out, that this group of children who received therapeutic hypothermia as neonates have decreased mortality, decreased neurodevelopmental disability in survivors, decreased severe cerebral palsy, and overall fewer deficits. So that was consistent with the 18 to 24-month outcomes in the original RCTs. That being said, some of the things that have been identified in these patients is that cognitive impairments in this population remain a critical concern, and a significant number of children, about 50%, are still going to have an IQ less than 85, with a quarter of them with an IQ less than 70. And there's been some thought that therapeutic hypothermia may not be as helpful for these facets of this disease and outcomes as some of the others. And so this is an active area of interest and research of how we can improve cognitive outcomes in this patient population. And in addition to that, I think, as clinicians, we think often of cerebral palsy and that sort of result from HIE. But what we do know is much more commonly, these kids end up with subtle neuromotor abnormalities, differences in executive function, attention and learning problems are very common in this population. So this is definitely an active area of research of where an interest of how we can continue to improve outcomes as far as the more cognitive and subtle neuromotor differences in this patient population. So the second question that I brought up there that had been a hot topic is more better? This is a great therapy, so can we make it even better by either cooling the babies longer or making them colder? So this was a study, a really nicely done study done by the NRN that was published in JAMA in 2017. And they looked at outcomes of babies who were randomized into one of 4 groups. And so essentially what they did is they either randomized babies to what is standard care, 72 hours of 33.5 degrees Celsius temperature, or a colder group for the same time period down to 32 degrees, or a longer group for the standard temperature, 120 hours, or both colder and longer. And what they found is actually they ended up stopping this trial early for safety concerns and futility, and that neither modification or the combination of both was found to improve disability at 18 months. And actually, the longer group, who was cooled for 120 hours, had increased mortality. So that was a well-done trial that showed us that no, in this case, at least as it was done in this trial, longer or deeper cooling is not advantageous to this group and may be harmful. So another hot question that came up, and I think often comes up for clinicians, is what if we start cooling late? I think we've all had the experience of getting a call from a referral hospital that, there's a baby at 12 hours who's seizing, or that, had a concerning story that was not identified before 6 hours, or can't get the therapy before 6 hours. And so this has been a really important question in the field to answer whether it's okay to cool babies later than 6 hours outside of what was done in those original RCTs. And actually, there was limited animal data that neuronal death may actually be worse if cooling was started late outside of that initial window. And so this was a study, again, also published in 2017, that was done over several years in, again, the NRN centers, 21 NRN centers, where they took babies that were identified late and randomized them into a late cooling arm or a normothermic arm. They unfortunately did not sort of, because of the limited sample size, this was a study that, as you can imagine, could be hard to recruit for, was done over 8 years. They used a Bayesian analysis because of the limited sample. And what they found is that based on the Bayesian analysis, that it's unlikely to be harmful, but the effectiveness past in the 6 to 24-hour window is unclear. So units have done, I think, several different things with this data. Some units have decided they won't cool late. Some units have interpreted this as there, likely isn't harm. It may not be effective, but it's worth doing. So speaking from our unit's sort of standard, we do consider babies outside the window before 24 hours of age for cooling on a case-by-case basis. And some units have a pathway for late cooling before 24 hours in that 6 to 24-hour window. Another question that has been, I think, a huge one in the field that's come up and been nicely studied over the last several years is cooling protective in all settings? So like I mentioned in my second slide, this is a huge global burden, and actually low and middle income countries have the highest rate of HIE compared to well-resourced countries. And so this was a really important question. And there were several smaller studies that showed that potentially this could be helpful. And actually ILCOR in 2015 recommended therapeutic hypothermia using some of these low-cost cooling devices that have been developed in low and in middle income countries, but it acknowledged the fact that there was very little existing evidence and it was pretty weak. So there was definitely a need for a large, adequately powered RCT in this space, looking at the use of therapeutic hypothermia in low and middle income countries. So the HELIX trial, as you see here, was published in Lancet in 2021, and it was a study that spanned over 2015 to 2019, so over 4 years, and involved 408 patients. Was unblinded, multi-country RCT over 7 sites, mainly in India. And they randomized patients to cooling or routine NICU care with controlled normothermia, so avoidance of iatrogenic hyperthermia in their control group. And they looked at 18 to 22-month outcomes with some other secondary outcomes, looking at MRI and biomarkers. The recruitment was quite good for this study. They had roughly 200 babies in each group, and a really amazing follow-up rate at 96% in both groups, which is really impressive. And unfortunately, what this study found, though, was that their composite outcome of death and moderate to severe disability was not different between the two groups. So hypothermia was not effective to avoid that composite outcome in this patient population in this setting. And the other sort of findings that from this trial were that actually the babies in the hypothermia group had a higher rate of some of the potential complications and side effects of cooling and HIE. So things like bleeding, hypotension, thrombocytopenia, death before discharge, and longer hospital stay. So the conclusions from the HELIX trial were that it was not effective, at least in that setting, and not recommended. This is, if anyone is interested in more about the HELIX trial, this is a really nice commentary done by some of the HELIX investigators, Sita Shankaran and Sunil Thayal, that was published several years ago, but it talked about sort of the history of therapeutic hypothermia in low resource settings and lessons they learned from the HELIX trial. And I think there have been other issues brought up that, and things that are problematic with some of the commercialization of cooling equipment that had been done before this Helix trial in low and middle income countries. And then there have been some ethical issues and research governance issues brought up in low and middle income countries as well to think about, not necessarily associated with the Helix trial, but just for some of this work that had been done prior. So another really hot topic issue in that's happened over the last 20 years in cooling is what about these babies with mild HIE? So these were, like I said, a patient population that was excluded from the original RCTs. They were thought to, mild HIE was thought to lead to very few adverse outcomes, and risk benefit may not be worth providing therapeutic hypothermia. But then there were a number of studies, the PRIME studies done by Lena Chalik and her group in 2017 and 2018 that were published that looked at mild HIE babies. It was prospective, and those that were not cooled, and found that actually what was originally thought, that these babies have very few adverse outcomes, was not true. And so in those cohorts, about half of them had an abnormal exam, EEG, or MRI, and 40% of them had decreased Bailey scores in any domain. So reason for concern there, and it really made the field think more about whether or not we should be providing cooling for this patient population. And one of the things that's come up over the years about this is there's really been a problem of therapeutic creep. So a lot of units have gotten extremely comfortable over the last 2 decades with cooling. And I know this is true, at least in our unit at UVA, we've definitely had therapeutic creep where if you're um, really wondering and you're sort of borderline on the story, the tendency is, if you have this great therapy that you know may help that baby, is to provide it even if you're not quite sure, maybe the baby doesn't quite meet criteria in your protocol. So there's definitely been a therapeutic creep internationally for providing therapeutic hypothermia. And what that led to is there really needs to be a good RCT for this, but it was going to be very difficult to recruit for and ask centers to do because there's been some loss of equipoise as far as truly randomizing a baby to therapeutic hypothermia who's in the mild category. But amazingly, Lena Chalik and several other sites have been able to come together to do the Cool Prime study, which is an ongoing study. It's 15 sites across the US and one in the UK. And what she did, instead of randomizing patients, is it's designed to take 7 centers that routinely provide therapeutic hypothermia per their protocol with mild HIE and 8 that do not. And it's an observational study that's planned to enroll 430 babies with primary usual outcome 18 to 24-month Bailey scores, with many other measures. Looking at developmental assessments, mother-infant bonding, parenting structure and attachment, parental mood and stress. Many of those outcomes are, sort of thought to play to the concern or answer the concern that some of these babies with mild HIE, if they're going to be cooled, may have to be transferred to a different center separate from their family, from their mom, to an ICU, and potentially stay longer. So there could be an effect on all of these other parental and infant bonding measures. Like I said, enrollment is ongoing for this trial. They have 185 patients so far, so it'll be really interesting to see what the results of this study tell us, hopefully in the next couple of years. And then I think the most recent hot topic issue in this space that has been ongoing for many years is, what about preterm infants? So the original RCTs excluded patients less than 36 weeks for the most part, due to concern that there were more risks in this late preterm population. One of the RCTs, which was a smaller RCT in those original studies done in the early 2000s, the Acre trial, did include 35 weekers. But there were not very many of them in that trial. Since there have been a handful of many retrospective studies looking at the safety of therapeutic hypothermia in this patient population, mainly late preterm, 33, 34, 35 weeks. And the AAP Committee on Fetus and Newborn has recommended consideration at 35 weeks or greater. Now, these guidelines are being modified at this point, but that was historically what had been recommended. Our center published actually 2 years ago, one of our fellows worked on this project with me and my colleague Santina Zanelli, and published the largest retrospective cohort to date at the time, which was about 40 babies, less than 36 weeks, between 33 and 35 weeks, that were provided with therapeutic hypothermia for HIE. And our findings were that these preterm babies that were cooled needed more inotropic support and hydrocortisone compared to our term group of babies that were cooled, but had similar incidence of injury on MRI and many other clinical factors, mainly related to bleeding, neck, and other safety factors that were similar between groups. Of course, that is limited. This is a retrospective review in our single center. So what we really needed was an RCT. And so the NRN did the RCT for preemie cooling across many years. This was also a challenging recruitment. Between 2015 and 2022, they recruited from 19 NRN centers and took babies born 33 to 35 weeks and randomized them to either therapeutic hypothermia or normothermia. And their primary outcome was death or moderate to severe disability at 18 to 22 months. And they also had many secondary outcomes, mainly looking at safety outcomes. As you can imagine, this spanned the pandemic, making recruitment difficult, and a study that was already going to be difficult to recruit for. They ended up randomizing 168 patients, about 80 to 90 in each group, and unfortunately lost several to follow up due to the pandemic. So it was definitely a more limited cohort than was originally planned, unfortunately. This study was finally published in February, and what they found was that for that primary outcome I mentioned on the last slide, was higher actually in the cooling group, so moderate to severe disability or death, compared to the normothermia group. And so the conclusions of this paper was that there was no evidence of benefit and potentially increased risk of harm. And if you think back to the late cooling trial, they also used a Bayesian analysis to ask the question, how likely is hypothermia to reduce the risk? And what the conclusion from the Bayesian analysis in this trial is that there's a 74% chance that hypothermia increased the risk of death or disability compared to normothermia. And so this has, I think, been a very controversial topic over the last couple months since this study has come out. One question that has come up is whether or not, we all as neonatologists identify a 33-weeker is very different from a 35-weeker. And so when you break this data down by gestational age, is that going to make a difference? And what you'll see here is that in the 35-week group, there is still some increased death or moderate to severe disability in the 35-week group that was cooled compared to the normothermic group. And so the study authors felt that this really should be applied to all gestational ages. And when you look into sort of the details in this study, I think a lot of the concern about cooling preemies was that they were going to be at higher risk for bleeding, for intracranial hemorrhage, for infection, neck, things like that. But actually, the majority of the deaths in the study were due to progressive multi-organ failure, withdrawal of life-sustaining measures based on the neurologic prognosis, not due to these other major safety outcomes that were measured that historically the community has been concerned about. So this is truly an evolving story. I think there are many units, including our own, that have included 35-weekers in their protocol. We were one of the sites in the ICER trial, so we had always cooled and included 35-weekers in our protocol, so we're very comfortable with that. And this is true for many units that have included 35-weekers in their protocol. So this is a hot topic, and this is just sort of some of the response, several experts in the field writing letters to and responses to that trial and with concern and questions about that very thing. There was a global survey done in the neonatal neurocritical care interest group in through the Newborn Brain Society that kind of asked centers across the world actually if they were providing therapeutic hypothermia for premature infants, and for some of that data. And there's a group of us, of centers and investigators, including our own, that are working on a brief report with the survey results there and some of that data that hopefully will be published in the next couple of months. So this is definitely a hot topic issue, and I don't think completely concluded at this point. So lastly, just to touch on, we've learned a lot about cooling, but we know that cooling doesn't help all babies. And so there has, over the last 2 decades, been a lot of research looking for an adjuvant or an alternative therapy to cooling for HIE. Many therapies, unfortunately, have been effective in preclinical studies, rodent models, even non-human primate models, and unfortunately have failed to show an effect in humans. And this is probably multifactorial. Rodent models are great for initial preclinical work, but they are limited in their translatability. And then we know this is a heterogeneous disease as well. And so thinking more about individualized targeted therapies, and trying to sort of think through all the different facets of that really complex injury cascade. And like I said in the beginning, probably one of the reasons that cooling works so well is because it's multi-mechanistic, and many of the studies that have been done on adjuvant studies that have not panned out to work have been very targeted therapies, so may not be as effective. And this is just a schematic showing some of the different therapies that have been tried, both preclinical and in human clinical trials in babies, including EPO, allopurinol, stem cells. That's another really hot topic area, melatonin, cannabinoids, inhaled xenon, amongst many others that are being studied. And probably the largest clinical trial in this space that's come out in the last couple of years is the HEAL trial, which was looking at a trial of erythropoietin for HIE in newborns as an adjuvant to cooling. This was a really exciting, well-done trial that unfortunately did not show a reduced rate of death or neurodevelopmental impairment in the group that received EPO. They recruited over 500 patients, and unfortunately found that EPO was not effective. So that was really disappointing. I would say this group of investigators that did this trial has done an amazing job, though, of really making the best of the data and publishing lots of other studies and sub-studies of this group, because it is a really large cohort of HIE patients. So a lot of questions can be answered from it outside of what the original question was. So what's the future of HIE research? So it's becoming more and more apparent across all neonatal studies, but also those in HIE, that patient and parental stakeholders are really important when you're planning these clinical trials. I think we, as a community of researchers and clinicians, have not done a great job historically of identifying what outcomes are actually important to families and patients versus us as researchers and clinicians. And this has become more and more of a topic that comes up while planning these clinical trials, while planning research. And so if you don't know about Hope for HIE, I would really recommend that you read more about them. It's a parent advocacy group led by Betsy Pylon, who's a mom of a baby, a child now, who had neonatal HIE. And she's an amazing advocate, but she's started this really wonderful resource for families, but also interfacing really nicely with clinicians and researchers to help guide some of these future studies and dissemination of information for families. I think another thing, as you may have noticed through these clinical trials, that these are really hard trials to recruit for, as are many neonatal studies. But thinking of creative study designs when equipoise is lacking, when recruitment is low, is really important. So doing things like the Cool Prime trial has designed sort of how they're going to recruit patients and units is going to be really important. Again, because these are hard studies to recruit for, being collaborative and using team science, registries if possible. So Newborn Brain Society is a great resource, Cerebral Palsy Research Network and Neonatal Seizure Registry are all great sort of places that have been able to really do this well and use registries or help investigators collaborate and get larger patient cohorts to answer these hard questions. And then there is truly a need for new adjuvant, alternative, and individualized therapies, because as we know, many babies are not helped by therapeutic hypothermia. So thinking back to this sort of timeline I showed you with landmark trials and findings in neonatal HIE, I think a lot of this will have to and has in the last several years involved bringing it back to preclinical trials, large animal trials, and going back into continuing iterations of RCTs involving adjuvant therapies to cooling. And there's more and more really research and interest on how to treat individual patients, knowing this is unfortunately a heterogeneous disease that can make it very hard to study and treat. So with that, a lot of information has been learned about how to optimize care for neonates with HIE over the past 20 years. Multidisciplinary teams can really help improve care, but also build these larger research collaborations to answer these difficult questions in this space. And many questions remain on how to best protect these newborns' brains and use therapeutic hypothermia for infants outside of the standard protocols. And just to give you two resources, again, I mentioned Hope for HIE. This is a really, this will link you to their website, the QR code, but they have wonderful patient resources in many different languages for parents whose babies have HIE. They also have support for parents later in the course of HIE after the baby leaves the NICU as well. So I would highly recommend going to their website and looking at what they have available. And then especially for the trainees, the Newborn Brain Society is great. And if you have any interest in newborn brain, they have memberships for trainees, a junior membership that's free, and they offer lots of good educational webinars and resources for trainees. So that's the QR code linking there as well. And with that, thank you all for listening so much and taking the time today. And I'm happy to answer any questions.
Thank you so much, Dr. Bernstedt, for the excellent and thought-provoking presentation. We really truly appreciated your insights and the depth of the expertise really that you have shared with us today on how the therapeutic hypothermia have evolved over the last 2 decades. So we'll now move on to the Q&A session, and everyone is definitely welcome to participate. There are 2 ways. You can either type your question in the chat box and I'll read it out loud, or you can just simply unmute yourself and call out your question directly. But before we begin, just a quick reminder, please take a moment to complete the session evaluation. You can exit through the QR code, which should be on the screen, or the survey link that has been posted in the chat box. And now let's open it up for questions. So I'll start with one, Dr. Bernstedt, since everyone's still gathering their thoughts. I'll go ahead and start. So as we reflect on those 2 decades of the therapeutic hypothermia, what do you see would be the most critical unanswered question or limitation in the current cooling protocols, especially regarding the timing or the duration or even the patient selection?
Mm-hmm. I think there's many critical, but I think the most hot topic issue right now, I think, is this one of, the preemie cooling, especially those 35-weekers. I think this is something many units are not sure what to do with the results of that recent RCT. And I think that's sort of a pressing issue to figure out, although admittedly a very difficult one to understand. I think the question of mild HIE, though, is really a great one, and hopefully the Cool Prime trial will help us with this. But I think that's a patient population that, like I said, we've always thought was going to have a relatively good outcome, and the risks of cooling may not outweigh the potential benefits. But that is an entire population of babies that we are not quite sure as a community what to do with right now. So I think those are sort of the 2 active cooling related questions. But I think in the field, truly, if you think about it, 2/3 of the babies that we take care of with HIE that we cool don't actually get significant neuroprotection from cooling. And so that's, to me, a huge deal. We've got to find something better. We've got to find something to add to cooling. And that's been sort of the big question that many very smart people have been working on for years. But I think that's going to be one of the most active areas of research in this space for many years to come.
Thank you so much, Dr. Bernstein. So actually, another question, since as you were answering and you brought it up in the middle of the presentation, Dr. Bernstein, is the adjunct therapies that I know that you have mentioned. There have been a few that have been tried, really haven't had a lot of success, including the xenon, the erythropoietin. Now there is some work including stem cell therapies, along, of course, with cooling. So based on your experience and the current evidence, do you think which adjunct therapy holds the most promise at this time? I know that there are still a lot of trials, and definitely in the future, a lot more suggestions will come out. But uh, with the evidence, with the current state of evidence, Dr. Bernstein, what do you think holds the most promise at this point?
Yeah, it's a great question. I think to me, stem cell therapy has the most potential and is the most interesting. I think one of the challenges with all of these adjuvant therapies, and I briefly mentioned, is that, a lot of them are really working on small facets of that really complex injury cascade that may differ from baby to baby. I think that's part of the challenge is this is a very heterogeneous population. And so, you can have two babies with very similar clinical stories, but have very different outcomes. And trying to understand the underlying reasons for that, genetic, epigenetics, all of those things will, I believe, be important to help guide some of these other therapies in addition to cooling. I think, we also know there's a lot of heterogeneity in this injury that's related to timing, severity, all of these other things that we see every day in the NICU in this patient population. And so I think until we understand sort of what those individual differences mean for that population, it's going to be very hard to get one of these adjuvant therapies to make a big difference in a large patient population in one of these larger clinical trials.
Totally understood. Is there any question? Any of the participants want to ask a question? I'll go ahead with one last question, Dr. Bernstein, if you allow me.
Uh-huh.
So sometimes it comes out as clinicians, especially in the resource limited settings, whether here in the US or even abroad, where cooling protocols really may not be accessible. What are some practical adaptations, like from your experience, or strategies that you'd recommend based on your previous experience?
And you mean like other therapies you can provide that are not therapeutic hypothermia?
Absolutely.
Yeah, I think that, what we have learned over many years, prior to cooling is that supportive care does make a difference in these babies. And so, I think one huge one is avoiding hyperthermia because we know that can make brain injury worse. And so if cooling's not available or for whatever reason that's not a resource, then at least, making sure the baby does not become hyperthermic would be very important. Treating infection, we know infection can make injury worse if there's a concomitant infection as well. And then, I think we've also learned hyper and hypoglycemia. So all of these other physiologic parameters can affect outcome as well. So trying to keep the baby normoglycemic, normotensive, and really try to keep many of the physiologic measures and hemodynamic measures in sort of the box, so to speak, is excellent supportive care. And if that is, the best you can do in those settings, then that is going to be an advantage for the baby and its outcome.
Is there any role, Dr. Bernstein, for passive hypothermia? Because it comes out a lot, and I've worked in a couple of underserved areas following fellowship, and that has always come up as a question. Shall we do it until the tertiary level brings the transport team? What are your thoughts on that?
I think you have to be careful with that. I think for us, at least in our center, we do get babies from very far away. And I know like in Virginia, that's nothing compared to what there are in other places. But we we started cooling and transport many years ago because we realized that babies were not getting to goal temperature till 12 plus hours on average if we didn't because of just our, space or referral area. I think the passive cooling question is hard. we do recommend that, but you have to keep a really close eye on the temperature because a lot of these babies, especially if they have severe HIE, if you just turn the warmer off, they will get too cold. And so I think, passive hypothermia is okay if it's a sort of transient thing waiting for the ultimate therapy, but the baby needs close, Q15-minute vitals and temperature monitoring to make sure that you're not getting too cold.